Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to reintroduce to you now. Dr. Vyvyane Loh is a very recent returning guest on our show. Check out part one of this two-part series by listening to episode 427 of Boundless Body Radio. Dr. Vyvyane Loh is board certified in obesity medicine and internal medicine. She is a member of the Obesity Medicine Association and the Obesity Society. Her other achievements include choreography and writing. She was the recipient of the Bunting Radcliffe Fellowship in Fiction in 2006, a Guggenheim Fellow in Fiction in 2008, and shortlisted for the 2005 International IMPAC Award in Literature. Her diverse skills support her commitment to celebrating the full range of our humanity in an increasingly technological and disembodied world through art and the healing sciences. She is also a host of the amazing podcast, the VLMD Rounds Podcast. Along her professional journey, she realized that much of the healthcare industry in which she was trained is, in reality, a sick care industry. And Dr. Loh was striving to change the paradigm of weight loss and obesity. We had an amazing time chatting on our last episode, and I expect nothing less from that this time. Dr. Vyvyane Loh, what an absolute honor it is to welcome you back to Boundless Body Radio.
Yay, it's a pleasure to be back.
I'm so glad you're back. I'm so glad that we ended up booking two of these within 1 week.
I know.
And get to come back. We got so excited and passionate about everything. It was fun to just hear you explain things and the way you think about things and how you are changing the paradigm of weight loss and obesity and dealing with chronic disease. It's really wonderful. And we love getting to know you and hearing your personal story as well.
Thank you. Yeah, I listened to my recording. I was like, oh, finish a sentence, will you? Because I got so excited.
It's great. It's great. We love it. That's how we know people are passionate. And that episode at the time of this recording has not dropped, but by the time this one does, obviously it will drop. It's probably a good thing that we're waiting to drop the first one because, a lot of times what happens with our guests is we drop an episode, then, they start to get the press and the accolades. They start having, the hordes of people follow them everywhere. They get quite famous and rich and everything. And so that's probably going to happen when the first episode drops. People are going to recognize you. And
I'm ready for it.
You're ready for it?
Yes.
You got to be careful. A lot of people turn to drugs and alcohol and all kinds of different things. So if you can handle the fame, then...
Yeah, my people will help me stay on track.
You got your people. Good. Good. Well, that's great. Okay, so last episode, you mentioned a phrase that I am absolutely fascinated with. And you talk about it a lot in your podcast, which is wonderful. I'm going to mess it up. Osteosarcopenic obesity? Did I do it right?
Absolutely.
Wow.
You did it right.
I've been practicing. Great. Okay. I think when we think about our bodies, especially those things, we think about, bones. What do bones do? They hold us up. That's pretty much all they do. What do muscles do? Muscles move your arm a little bit and help you walk or run or whatever you want to do. And fat is universally hated by everybody. It just sits there and nobody likes it. Everybody wants it to go to zero and be gone. And that's kind of how we think about these things. And I don't think we think about the link between all of them. And I don't think we know how complicated some of these things are. So I don't know if there's a place you want to start with that, but I'm just going to put that out there as far as that term. And I would like to know how you think about that.
So yeah, with osteosarcopenic obesity, so the osteo is the bone, sarcopenia, we're talking about, muscle, actually loss of muscle, and then obesity, which is a fat mass and fat dysfunction issue, right? So even the term obesity has been oversimplified and misunderstood. So mostly we think of obesity as a weight issue. If we are a slightly more sophisticated, then we'll think about it as a fat mass issue, too much fat, right? But it's actually that plus dysfunctional fat, okay? So we have to look at the function and then also the quantity or the amount of fat that we have to actually define obesity, but that's rarely done. So right now we just look at a number on the scale and that doesn't even look at how much fat you're made of, okay? And the reason that we're not successful in countering obesity is because, like I said, we don't even understand the problem. We think of it as a number on the scale. Now, if we're dealing with fat mass and fat dysfunction, the main thing to recall is that in a sense, because what you just said is true. A lot of people come to me and they say, get rid of all the fat, Dr. Loh, help me get rid of this fat, right? The thing is, some of this fat is protective. It's a buffer. And it was made that way for us to have metabolic flexibility so we can store in times that we need, right? That we have plenty, and for times where we might not have enough nutrients, okay? But we want to store it in such a way, it's accessible, but we don't want the fatty acids floating around in our bloodstream because they can be very toxic. And then then the fatty acids can become different lipid species like ceramides and so forth. And those are very, very toxic, okay? So one way to do that is just to sequester it in fat tissue that was made to store these lipid droplets, right? The oils. Okay, but then there are places in your body which was never made to do that. But when you run out of storage room in the real fat tissue, then we're just going to stuff it somewhere else. And that ends up being in organs, in the viscera and so forth. So when we say visceral fat, we're actually talking about one component of ectopic fat, ectopic meaning out of place. So fat where it shouldn't be, right? And you shouldn't have fat really in your liver. You shouldn't have fat in your pancreas or in your kidneys, right? So you have fat around the kidneys, but you don't have fat in the kidneys, for example. So ectopic fat and visceral fat is, one type of ectopic fat. But it's a great proxy because if someone has a lot of visceral fat, then you can imagine that they probably have fat that's out of place in other regions, in the liver, in the lungs, for example. People don't think of fat in the lungs, but asthma, COPD, right? A lot of it is reacting to the toxic substances that the fat in the lungs are actually putting out. Okay. Nobody thinks of fatty lungs, fatty liver, but no fatty lungs, right? That was actually confirmed in 2019, and they actually saw, ectopic fat in the lungs.
Wow.
Okay.
Yeah, that's crazy.
Yeah, which is why, again, if someone has asthma or COPD, chronic obstructive pulmonary disease, really, the indication is to get rid of that fat. That's causing a lot of the irritation, right? Someone has atrial fibrillation, that's fat in the heart, right? And that fat is irritating the heart. It's interrupting conduction pathways in the heart and so forth. Okay, so then the primary indication is you have to get rid of that kind of fat. All right, so we have different compartments of fat, and generally we were made with fat tissue to help buffer, these fatty acids and have a storage place for us. But when you run out of space, then you get into trouble because now you start indiscriminately storing it in other places, right? So when you see a patient, you have to assess, where is this patient? Yes, the patient may have obesity, okay, but that's, by just fat mass. But that's not as bad. This is not, so it's on the spectrum. It's not as sick as the person who has increased fat mass and now spillage into the ectopic compartments, okay? Now, so if you just have increased fat mass, that's what is generally known as metabolically healthy obese. So people say, oh, you can be big and still healthy, right? So that would be metabolically healthy obese because we are storing the fat in the appropriate place. The bad news is most people who are metabolically healthy obese will convert to metabolically unhealthy obese within 7 years.
Oh, wow.
Yeah, most people will convert within 7 years and everyone will convert within 10 years.
Wow.
That's what the data says. Okay, so an example is I have a patient, she came to me and she was over 40-something%, quite high, 48% or something, body fat, but she had it all in the subcutaneous, right? Like a lot of women, it's in the gluteal areas, the hips, the thighs. Okay, and she had very low visceral fat. But she came back 3 years later, she was a little higher in percent body fat, and now she had accumulated all of that fat inside the abdominal cavity. What a change. Okay, weight was, maybe she gained 20 pounds over the last time I saw her, but body composition and where the fat was had changed. So, metabolically now, she's not the same as she was 3 years ago. And you have to recognize that she's in a worse situation now. So what she did was she converted from metabolically healthy obese to metabolically unhealthy obese within 3 years. That's generally what I see is very common. Okay.
Wow.
then number one, now the first thing when I see that, I always look at the muscle mass. Okay, and you will almost always see a corresponding decrease in muscle. Okay, sometimes the muscle will stay the same. That's can be very deceptive, right? When you adjust, by the time you adjust for the BMI and all that, you actually find that they actually have less muscle mass. And even if they keep the same muscle mass, they have poorer quality muscle. So when you define sarcopenia, again, like fat, you have to look at mass, so the amount of muscle tissue you have, and we're talking skeletal muscle, not smooth muscle here. But okay, we look at the amount of muscle, then you have to look at quality. So when sarcopenia is strength, which looks at quality, right? Strength and performance, and then muscle mass. So there are two components. So again, we have to make sure we dial in. It's not just how much you have, what's the quality of that muscle.
Yeah, that's
Okay?
such a good point.
Yeah. And then, people who have poor muscle mass, they're going to have poor bone. All right, bone, same thing. Bone mineral density is what we're used to looking at. All right. And then the thinking is the more dense your bones, then the stronger they are. That's the general thinking, right? Except that Asian women, for example, have lower mineral density, right? But they rarely have fractures, not compared to like Caucasian women. They have stronger bone because the microarchitecture of the bone is different. Right. So the quality of the bone is different. The structure is different. So again, we're looking at the amount of minerals, but we also have to look at the quality. So in all aspects of metabolically healthy, of metabolic tissue, whether it's fat or muscle or bone, you have to look at mass components, which, okay, if we do think that way, we generally just look at the mass, but you have to look at the quality of the tissue as well.
Wow. So
Right.
when you get one of those things, do you get all of those things? Like if I
Yes.
start gaining a lot of fat, I notice that I at some point will be losing muscle, and also my bone quality and density, both of those things, like you explained, is also getting more poor. All of those things come
Yes,
together.
because it's a fat muscle bone axis, right? And your body composition, you impact one part, you gain more fat, and yes, you gain some weight, but a lot of times you're going to shift the axis and you're going to have less muscle bone and poorer quality muscle bone. Okay. And then this perpetuates the cycle because a lot of the sick fat is highly inflammatory to muscle and to bone. So type 2 diabetics, for example, have, this is very well known, accelerated muscle loss. Okay, which is a terrible situation because we talked about this a little bit last week. Think about this. They already have type 2 diabetes. So they're struggling with high blood sugar, right? And they're in a situation of accelerated muscle loss. What did we say about muscle last week? If you shrink the muscle compartment, right? Now, where is the sugar going to go? So we get that person, maybe even cutting some of their carbs, okay? But they still have this toxic fat, visceral fat. And a lot of people will lose weight, but they still will have a huge amount of visceral fat. This is very, very common in my population of patients. That's why, I never say you're done until I look to see where the fat is and I know what kind of fat it is, right? So someone will lose, let's say 60 pounds and their doctor is really happy. I'm like, no, you still have huge, all your fat is in the visceral compartment, and that is decimating your muscle, for example, causing fibrosis in liver and so forth. So, we're not done. Okay, so now here we are. You may have lost weight, so you lost some muscle as well in that weight loss process. But here's the thing, now you may be eating better, quote unquote, but there's a smaller reservoir to contain the glucose. So there's more spillage. So we set up this accelerated cycle, right? So this is why it's really important to preserve muscle mass, especially in people who already have metabolic disease. Okay, you're already in an inflammatory situation, and now you're losing muscle, which is what we need you to have, bulk up on, so we can take up as much glucose as possible. In fact, one of the effects of insulin, I don't know if I made it clear last week, right, is to increase the blood flow to muscle, open up capillary beds in the muscle, because we want to prioritize the glucose being taken up by muscle, right? You have a smaller muscle component, you're going to watch that blood sugar go up, right? So, we're, again, not really thinking ahead when we are dealing with those patients. Bone is where yes, it's for structure and so forth. Bone is also where we store minerals. People don't think about it that way, but you're storing your calcium, your phosphate, your magnesium in bone, right? And, when you need it, you're going to kind of go to the bone bank and get some calcium and so forth. So that's where we store minerals. That's number one, right? And it has a lot of metabolic signaling because it secretes hormones. All of these tissues, fat, muscle, and bone, they are hormonal tissues because they secrete hormones, all of them. And these hormones talk to each other. Okay, so not only are they, regulating, your bones are regulating metabolism as well, but if you think of bone marrow, you realize that that's where your immune cells are born, right? So, your bone has important immune functions. It's where your immune cells are born. In fact, some of the bone cells, like osteoclasts, they are really made up of immune cells.
Wow.
So I don't know if you watched, but actually was a talk I gave at IHMC called the Magical Mystery Macrophage Tour.
I've seen that. I haven't watched it.
Yeah, that's on YouTube. And I look at macrophages, but I just want to point out that osteoclasts, which are the cells in bone that break down bone, they are really macrophages, right? So they are immune cells, Yeah, so yeah, bone is very interesting that way, right? Bone also, in the bone marrow, harbors fat, okay? And, bone marrow fat is in itself quite interesting. The relation between bone marrow fat and sarcopenia, there might be signaling properties that impact muscle directly. If you imagine the muscle is inserted into bone, so they're really in close proximity, especially at the periosteal surface, right? And so there's a lot of signaling that goes on at those junctions, right? So I never think of a patient as a certain weight or BMI. I don't even, yes, I use percent body fat, but I'm always thinking, if you move one component of the fat muscle bone axis, you're going to move other components. And you want to regulate and optimize that body composition for the person, right? So if you look at, I see a lot of people, and maybe they put themselves on their own, whatever, dietary regimens, or maybe their doctors put them on something, right? Or even medications or surgery. Okay, any of those, ways to lose weight. The problem is we are only looking at weight, and it is really hard to get people to kind of, move away from just fixating on weight. Patients have a hard time looking at anything else besides weight. But you can have two people who are the same weight, same BMI, same height, right? But one is primarily muscle and the other one is more fat. They're going to look very different. They're going to need different clothes. They won't be able to fit into each other's clothes well. And they're the same weight and they're the same BMI, right? So this is something, it's very hard to get people to think along those lines. And this is why we're not moving obesity, we're not moving metabolic disease, because the criteria, what we're looking to judge our effect is actually very poor, right? Looking at a number on the scale. And, you wonder why. So like I said, I have tons of patients who've lost a huge amount, and they lose 100 pounds, right? And visceral fat is still really up the wazoo. So now I'm like, we still got a ways to go. And they're like, but I'm skinny. I'm going to look gaunt. Okay, so this whole Ozempic face thing, right? I was just like, okay, it's crazy because, any significant weight loss, you see that, right?
Mm,
And especially if that person lost weight in such a way that a lot of the weight is also protein and muscle. Okay, so yeah, if you're losing muscle, that's going to hang very differently than if you're losing more fat, right? So how do we optimize that? And then once you've lost the muscle, not so easy to regain.
that's right.
You're over the age of 35, it's going to be a challenge. If you've
Yeah.
lost 20 pounds of muscle, which a lot of the, let's say, bariatric patients do, and you're, let's say, 45 years old, you're probably not going to get all of it back.
Yeah.
It'll be hard, especially in a woman, to even get 10 pounds back.
Yeah. And then what happens is they take the fall and break the hip. And such a large percentage of people who enter the hospital after they've had the fall don't ever come back out alive anyway. And so it's really sad. It's tragic to hear all of
Yeah.
that. I had a similar experience just this week. I started with a new client recently. We found out she's in her, I think she's in her 40s, and just found out that she was eating like maybe 60 grams of protein a day. So we said, okay, really need to up that. That's like bare bones, absolute minimum. So she's getting about 3 times that now, about 140, 150 grams, not exactly 3 times, but in that ballpark. And she's feeling great. She's noticing the benefit. She does feel stronger, but she started complaining because she was like, I gained 7 pounds. Are you kidding me? I gained all this weight. This is ridiculous. Why should I hire you if I'm gaining weight? And I said, well, what about your waist circumference? She's like, well, it's down 2 inches. There you go. Where do you think that weight is going? It's going to muscle. It's going to bone density. It's going to build connective tissue and all kinds of other things that you talk about all the time. This is non-fat mass. There's all kinds of different things. It's not just muscle, although that's part of it. Your body is healing and repairing and using it. So your gravity weight on planet Earth is so irrelevant.
Yeah, but that's exactly my experience with patients. I have the same experience, right? People are upset because that number on the scale, and you dex them and you're like, dude, you gained muscle, we lost fat. And they're like, oh, well, and yeah, I noticed that my pants are fitting better. And I'm like, yeah, right. Why didn't you tell me? Right? They'll tell you, they'll complain about the number on the scale. And it's like, oh, please. We gotta
Oh,
get
but
away.
I'm thinking more clearly, and I don't have brain fog, and I don't need naps anymore. And like, there's all these other positive benefits. Like, don't worry about that one thing. This might be a good time to talk about this. I was going to ask you at some point, how were you analyzing? And you just mentioned DEX, so DEX for DEXA. Can you tell us a little bit about that measurement and how you're using it in clinic?
So yeah, so that's the same machine that people use to measure bone density. So I'm always, wondering why it seems so hard to get people to use the DEXA, because we already have it in most institutions. And a lot of people are ordering bone densities on their patients to check for bone mineral content, right? Well, it's the same machine and really very low radiation dose. So it's less than 1 day's ambient exposure to radiation. If you've gotten an airplane and, I'm on the East Coast, if I flew to the West Coast, in that one flight, that's 1 week's exposure to ambient radiation, right?
Wow.
And the DEXA is like about a day. And so you actually can DEX babies, you can DEX, pediatric, and I certainly have, because the radiation is really negligible, really. Right. So the other thing about that is it correlates to CT results very well. Now, CT high radiation doses, so it's not a good idea to sequentially follow the body composition with CT, because if you keep doing CTs every, even twice a year, that's a lot of radiation dose. But I can DEX my patients every couple of months, 3 months, right? And if we put them on a certain regimen, I can see in 3 months whether we're doing anything or not, right? Sometimes a patient will tell me, oh, I'm working with a trainer. And I was like, let's see if your trainer's worth anything, how much you pay them,
I love it.
right? And then I dex them and, I can be very specific. So for example, I have patients and they maybe had surgery, orthopedic surgery of some kind, right? And we have their DEXAs. So you can see the, muscle mass on the left leg is different from the right. And, we can tell them, look, you're like 1 pound less muscle. on your left leg. And you really have to, that really motivates the patient because they can see it, right? And then in 3 months, I need to see that number go up. So there's something to shoot for. So they're really, kind of attentive to the PT and whatever else, right? So yeah, I like using the DEXA, and it's also where I'll tell you this, okay, anytime I have a patient population, I think it's not just my patients, but when they gain weight, they go, but Dr. Loh, I've been going to the gym, so I know it's all muscle. Well, let's see. Hate to tell you, right? So, but here then it's right there, right? It is either muscle or it's fat.
Yeah.
Right. And so there's no second guess, because a lot of times people go, well, I've been going to the gym, I think it's muscle. And no, so, and I know that's always a bummer for my patients, but many times if they are following the regimen, they do see improvement, they see increased muscle mass, and they're very motivated to keep going, right? So having something meaningful to follow. So it's funny because a lot of times people are like, oh, we look for this biomarker and that biomarker, and there's a new blood test. And this is something, it's a 7-minute test. They lie there, there's almost no radiation. I read it right there and then, right? You can do it sequentially, you can keep following them. There's no sending them to a lab, there's no blood draws involved. Very quickly, you can assess this person metabolically. Now, I do use blood tests, just to kind of, and I always say the blood test is not for me, it's for the patient.
Yeah, that's a really
I
good
can look
point.
at you, I know what your blood test is going to say, right? But hey, you know what? You need to see it, to see where you are and why we're concerned, okay? So people go, did you see my, I'm like, yes, I saw it before I got the test, clairvoyant. So I can just read it, I can douse you and just say, oh, this is where your triglycerides are. So, but like I said, I always order those tests. It's more for the patient than for me, but to follow and know where we're headed, I can very quickly look at the DEXA, get it right there. And then, like I said, 7 minutes, I print it out and I sit there and I go over and I look, all the fat you gained is visceral fat. It's all in the visceral compartment. That's bad news. And they're going, oh yeah, I've been needing more insulin. Oh, duh.
Yeah,
right.
Interesting. Wow. Okay, so I always thought that DEXA was not only cost prohibitive, but it was difficult to find. Like not every place had it. And it sounds like I was either wrong about that, or I'm definitely wrong about that now, and it's become a technology that's a little bit more available.
It's very available, but I think that practitioners don't know to order it and how to read it, right? And so I've done a lot of education, and I've even just done seminars for people to understand how to read a body comp and things like that. So it's actually, the machinery is there in a lot of clinics and facilities. Radiation is so low, you can use it in babies. It's very safe. The cost, my understanding of the cost is it runs around $100 to $150 per scan. Right, which is not prohibitive. It's not like a CT scan or a MRI scan, and you get very accurate results. And you can now follow. Not only do you see the fat mass and muscle mass, you can see where it is. You can actually look at which limb, right, trunk area. You can see where it is, and you can work on balancing out your body comp that way. So it's very useful. And, when I send my patients back to let's say their personal trainers, the trainers love it, right? Because here's a very concrete way to follow your progress.
Yeah. No, that's fantastic. We use a scale. The brand is Embody. They use electrical impedance. It's an in-home scale, but people can download an app. And we can show them muscle mass, fat mass. I'll generally tell people like ignore whatever it says for basal metabolic rate. It's just an assumption. I really want to see your muscle mass. The fat mass is something we'll work on that over time. But if I'm seeing your muscle mass come up or at least be maintained, I at least know we're heading in the right direction. That should help with fat mass eventually. And it's something. It's better than a normal scale, but it's very limited. And one of our former guest, Dr. Sean O'Mara, he uses scans as well. And he says with visceral fat, it's super, super helpful, not just to say you have 5 pounds or 20 pounds or throw out some number. No, like actually look at this. Do you see all of this space that most doctors miss? They don't even look at it. This is telling you something. And he claims that it's that visual that's way more impactful on his patients.
Yeah, I have a physician who was my patient, and when he saw his DEXA, and I read it in front of him, I showed him, I said, "This, you see this? This is all fat. See this yellow? Yellow is fat." And he was shocked, right? That was what got his attention. Now, with those bioimpedance scales, usually for percent body fat, if it's a man, I would add 10 to 15 points to it. Okay, so if you see 5%, you're running 15 to 20% in that person. If it's a woman, you're going to add 20 to 25. Never been wrong. I've never been wrong. Yeah, I got a call from tell this story, but I got a call from a radiologist in Texas who had never used the DEXA for body comp. And the call was, there must be something wrong because it's so inaccurate. I said, "Why do you say that?" I said, "Because it doesn't match. They were using the bioimpedance one before." And I started laughing. I said, "Here, this is what you do." And I gave him this. I said, "You just add and it should work out." He came back, he said, "Oh my God, that's exactly right." I was like, "Yeah, because I've done this for years." All right. So, and it's really funny because people will say, "I'm 4% body fat." I'm like, dude, that's very sick. You're 4% body fat, you will have huge insulin resistance. You would have a massive liver because that condition is called lipodystrophy, right? And it takes a lot of people by surprise, especially those who are used to kind of like being healthy and exercising. And they're like, "Oh, I'm 4%, but it's like, oh no, because if you were, you'd be a very sick person, right? And lipodystrophy is exactly the problem of not having healthy fat tissue. So these people don't have enough subcutaneous fat. Now remember, you do have to store somewhere. So if you're going to store, you need to store in the subcutaneous compartment. So if you're born with very little subcutaneous fat, right, then where are you going to store it? There's no other option in organs, liver, heart, lungs, So people with lipodystrophy are very sick. They are low percent body fat, but whatever fat they have, it's in the organs. Okay. It's really, I've never seen anyone who's 8% body fat and it's all subcutaneous. Okay. So by CT, 8% body fat by CT, which correlates to DEXA. Okay. That is lipodystrophy. That's how we define, we look 8%. Okay. So when you have a percent body fat, like you said, sometimes that's all you have. This is what you do. If it's a guy, you tell them, we add 10 to 15. And I base it on you do the eyeball test. If the person is leaner, you can add 10%, right? If they're a little fluffier, then, you go to what's the 15. Okay. Same with a woman. Woman, I will add 20 to 25 for sure. Right. So I often have women say, "Oh, I was at the gym and I was 18% body fat." I am not 18% body fat by DEXA. And I'm like, I don't think so, because you would be very unhealthy if you were. No woman should be really below 20%. That would be pretty bad. I'm even concerned if they hit the 25% mark for that's the criteria for men for obesity, right? If women are below 25, that's cutting it pretty lean, and I would start to worry. But definitely you should not, as a woman, be below 20%. You'd be very, very, very sick.
Yeah.
Okay. So when people say that, they're not aware and they don't understand that it's that whole concept. Get rid of all the fat. The lower, the better. That's not true, because if you get rid of normal fat tissue, then you have no choice. The only storage place is in organs.
Yeah.
So you better have some fat tissue that's normal, the subcutaneous. You see what I'm saying?
Yeah, no, I do. So anybody who complains at us when we tell them that actually they're more fat, they have more fat than what our scale tells them they do, I'm going to give them your cell phone and your home address, and they could write you all the hate mail, and I'll say, look, it wasn't me, it was Dr. Loh, it was Vyvyane Loh, that's what she says. And no, that's a really,
it's
a good
absolutely
point.
true. Yeah,
Yeah.
because you don't want, I mean, again, if you look at the lipodystrophic patients, they have huge bellies, and it's not because that they have fat under the skin. It's that fat is an enlarged liver.
Yeah.
That's protruding from the, you know, so their organs are so filled with fat that they have these big bellies. And I'm like, you know, I hope you realize that's not healthy, right? And that's not subcutaneous fat, and that's the big problem. And actually, if you transplant subcutaneous fat, the insulin resistance goes away. They become much healthier. The liver fat goes away, right? So it's because they don't have real fat tissue.
Yeah, no, that's a fantastic point. And I like to think of visceral fat as like, yes, it's in the internal cavity, and it's not the fat that you pinch. It's not the fat that kind of jiggles around and moves around outside. Like, people don't like that, but that is the healthy kind of fat, like you said. The visceral fat is like, you could, bounce a coin off your stomach or whatever. Like, it's so internal, and it just, all of this to me sounds like something that our body does it really well and really efficiently. And it's like, we are going to avoid a short-term catastrophe, a short-term crisis. We got to kick this can down the road. I can't have your blood sugar too high. I can't have your blood lipid be too high, your triglycerides also, all of these toxins that you're talking about. Let's, short term, we just can't have a crisis. So let's stick this somewhere. We'll deal with it later. Don't really know how, but we'll figure it out. And we never figure it out. And so the chronic diseases just get worse and worse and worse as your body's just fixing all these short-term fires the best way that it can.
That's right. And, every night, you have a period of fasting, right? You go to bed and you're not eating, and then you want to utilize fat. And normally you should have the compartment in the subcutaneous tissue, and then your body will extract and use it from there. That's just generally how your body works, right? But again, if you don't have any of that fat left, then you're in trouble. And what I like to say, people ask me, so what's your approach to taking care of patients? I'm like, get out of nature's way. Okay.
Thank you.
It's like, I'm just like, you just let Mother Nature do her thing, because she knows what she's doing. Just get out of the way. And what I try to do is just kind of allow the body to do what it knows best,
Yeah.
And what happens is that we interfere with our natural processes, our natural rhythms, right? We interfere with our own biology, and then we want to fix it with more interference through pills and so forth, right?
Yeah.
And I was like, get out of the way. It's all you need to do is get out of the way.
That's such a wonderful point. And this isn't for everybody all the time, but generally speaking, for a lot of people out there, if you can alter the diet to the point that you have the ability to intermittent fast, to me, that is one of the very best examples of getting out of nature's way and letting the body just kind of sort things out. And sure enough, it really seems like it does that quite a bit. Again, there's lots of caveats there. You got to do it right. You've got to be the right person. But I've found that, like, if you're following the laws of nature and you can fast and you just start to extend that window, you can achieve healing. Your body will sort it out with all kinds of different ways. It's really cool.
Yeah, I think that 12 hours is reasonable for everyone, just because, you're sleeping at night and really you shouldn't be chomping down the whole night. Okay. Although, 30% of patients with obesity, pretty high, they have night eating disorder, so
really,
you'll see that.
I didn't know that.
You'll see a lot of people. Yeah, it's pretty high. And definitely in my patient population, I see a lot of, you ask everyone, most people do well early in the day. Mid-afternoon, they start to get into trouble. When they get home from work or in the evenings, that's when all hell breaks loose. And if they're going to make poor decisions, they tend to be at the later half of the day, right? And then they have what we call morning anorexia, which means they wake up and they're not hungry. That's not normal, okay? And that's against your biorhythm, right? Your circadian rhythm. You really shouldn't be eating that much at night, So so they're already they have disordered rhythms, disordered eating, right? And you have to try and set it. But so I think 12 hours is reasonable. Extending the window for some patients at certain points in time is very reasonable and good, especially if you're trying to, you have some metabolic aim that you're after for that period of time. The only problem with that, not the only, but one of the big ones that you're going to hit is, so now we have a 45-year-old with anabolic resistance, okay, postmenopausal woman. And she already been dieting her whole life. She doesn't have, I have people very common, thin women. Casey, I can't tell you how common this is. Thin women, BMIs 21, 20.
Wow.
Percent body fat, 44, 45.
Wow. Wow.
Okay. These people have normal weight obesity. Muscle mass in the bottom 1%.
Wow, that's so bad.
In the first percentile. Oh, is that good? No. 99% of people in your age group and your demographic have more muscle mass than you. That's what it means, right? Very common. I see this a lot. Okay, now we have this person and they're trying to lose weight because again, it gets harder because now they're mostly fat. Okay, so they come and I hardly eat, Dr. Loh. Okay, all right. And then they try intermittent fasting. And I'm trying to get protein in you. Oh, I'm so full. I ate one meal. It's okay. I do this intermittent. We're never going to catch up. Do you understand?
Yep.
Your biggest problem is you already don't have muscle.
Yep.
Right? So this is the population. I have a clinical population. I have people with diabetes with accelerated muscle loss. I can't do that.
Yep.
Yeah.
Good point.
In the short term, yes, Casey. I may have to. Right? But long term now, the long game is I got to get you some muscle because otherwise your muscle mass shrinks, blood glucose is going to go up too. So, you can't look at one, just one point. You have to look at the whole picture, right? So in those patients, right? And then the other thing about obesity that never gets discussed is, listen, there are two things going on. Okay. One thing is the obesity, which we already defined. Every person, every, I've done this for a long time now. Every person with obesity has malnutrition. Got it? They're malnourished. They don't have enough nutrients. They have calorie-rich, dense energy foods with no nutrition, right? Just chug down some high fructose corn syrup. You see what I mean? There's no nutrition there. Okay, so every time you see an obese patient, this is why all these people with obesity, give them this and the weight drops. And I'm like, all of them already have nutrient deficiencies. Okay, now they're not eating because the Ozempic takes away their whatever, and I'm just like, oh my God, you just like, you're supposed, you're a professional, so you should know your field. And, pretty much every patient with obesity, just if you see a patient with obesity already straight away, malnourished, malnutrition, right? So there are two things you have to do. You have to address the body composition, and you must address the nutrient deficits. Okay, these would be all the micronutrients like the vitamins, the minerals, right? All of them are vitamin D deficient. Obesity. Okay, and the other thing about obesity is like, don't forget that vitamin D is fat soluble. Okay, so a lot of the vitamin D, even if you give them supplementation, is stored in the fat. So it's not bioavailable. You see what I'm saying? So as they lose weight, that's why if I supplement someone, I watch, because you can see a very quick rise, because as they're losing the fat, they're releasing the vitamin D. Same also with thyroid, right? It's stored in the fat. So if you're doing any thyroid replacement, you have to watch if they're losing weight, So anyway, the whole point is that they don't have any bioavailable vitamin D, right? And they really have poor mineral nutrient content in their diets, for example, and the rest of the vitamins and so forth. Most of your diabetic patients, I always give thiamine and the B vitamins. because all the cofactors in your crepes, right? All those B vitamins, yeah, and you have high sugar, you're using up that cycle, no replacement. Hello, right? So you see a patient with obesity, or metabolic dysfunction. Okay, so everybody says, oh, metabolic health, I'm doing metabolic health. So you have to address both components. One is the body composition and then the nutrient status. That's a minimum.
Yeah.
There are other things, and then you adjust, you try to figure out how much inflammation, anti-inflammation, you want to get them back to a homeostatic balance. But, the basic is you have to address the fat muscle bone axis, and then you have to adjust the nutrient axis, right? Those two things. So, anytime you treat a patient for metabolic health, you gotta have that approach.
Yeah, no, that's so well explained. It's such an interesting paradox that I think tells you exactly where we are with our food these days and our food consumption and production. I'm willing to bet that there's not any other species of animal besides humans and the domesticated pets that we feed that have the double problem of overweight and over calorie and under nutrient. It couldn't happen. That makes no sense. It would be a paradox.
Casey, last episode, right? I talked about how the whole family is obese, the dog's also obese, right? And
I love that story. I've stolen that many times with my clients over the last few days. It was great.
Think about this. I know 20 years ago, 30 years ago, Rover died of old age or was run over by a car or something, right? Now Rover has diabetes, all the skin diseases, they all have allergies. Okay, Rover used to eat scraps from the table. Now we have all this processed stuff that we feed Rover with, right? The vet says this is an amazing formula, but it comes from the same place that makes your general generic pet food. Okay, so yeah, pet food is the most processed. Because you have downed animals, like sick animals, they can't feed it to humans. That goes to the pet food industry. And then they just, make it tasty and they put all kinds of processed stuff that's cheap and your dog loves it or your cat loves it. Okay. So like I said, when they were eating table scraps, died of old age or got run over by a car, that's how pets died. Now they have autoimmune disease, right? They have severe, they have bloody stool, they have colitis, they have, like I said, diabetes. They need the kidneys are gone, right? And I'm like, seriously, right? So this is, if you look at it, what's changed is what they're eating.
Yep.
Duh.
Yep. Yeah. Now, one of the more fascinating episodes that we ever did was with a veterinarian, Travis Enertson, and he was working with diabetic cats 20 years ago and found somebody who was reintroducing cats to their proper diet and started giving diabetic cats wet cat food and describes these cats like getting healthy and jumping up on shelves again and like doing push-ups and pull-ups and like getting way stronger. Same with dogs. Like it's a different diet, but it's in that realm. And like they're reversing diabetes in cats and dogs who should live 20 years.
Absolutely. It's absurd what's going on, right? And we just continue to deny that our nutrition has anything to do with the state of our health.
Yeah. No, that's such a good point. We've already covered a few take-home points, and I know we did this last time as well. But when we're looking specifically at where you call this axis, the axis of the bone, the muscle, the fat, there is things that we can do. We can reverse this. This is not a death sentence. Just because you're diagnosed with something does not mean you have to live with it, regardless of whatever your general practitioner says. So what are some of the practical take-home tools that somebody could be thinking about when dealing with all of these problems together so that they could improve the entire system and improve all of those things versus like just independently trying to fix one thing or another?
Yeah, my biggest approach, and I'm sure you've already heard, I do cut carbs, especially the processed carbs, right? And people go, oh, okay, you mean like just like the Doritos and stuff? And I said, no, the bread too, that's processed. They're like, oh, right? So, basically try to eat foods of one ingredient, right? Broccoli, beef, beef, fish, eggs, yeah, sure, you can put salt or whatever spices you want on things, but foods of one ingredient is a general easy way for people to grasp this concept. But I do tend to cut their carbs, especially when I see them for the first time, because that generally really gets people in a much better place and unhooks them from the cravings and addictions that also kind of perpetuate that cycle, right? So there's that behavioral component as well. So attention to the diet. I put everyone on a schedule, okay? And the reason is that, besides getting your sleep in order, because that impacts your metabolic function as well, right? The second most important clock setter is the timing of your meals. The SCN is the primary clock setter, but we have local oscillators. One of the most important is timing of meals. So I set the clock and I prioritize it to follow the circadian rhythm. And then obviously we set them on a path where you want to get them doing more resistance training, right? And moving more. Now, exercise isn't going to help you lose weight necessarily, but actually exercise is very effective in addressing the visceral fat, number one, okay? And number two, it does, there are so many things it's good for your brain, right? And for your cardiovascular health and so forth. But if you're doing resistance training, especially, then we will get, hopefully more hypertrophy in muscle and better quality muscle. You can, obviously you have to address the nutrition to not have sarcopenia happen. So we do have to make sure that people get enough protein, right? To your point, that 60 gram, just pathetic, right? Pathetic. I see a lot of renal patients, and it's just, they're better now because the recommendations for renal patients is higher now, actually quite reasonable. So, you want to prioritize the protein, but you're still not going to get increased muscle mass if you don't do the resistance training. So sorry, you got to do the resistance training. Right? Yep. But back to the sarcopenia, right? In renal patients, very common. You see a renal patient, sarcopenia. Just think that. Every nephrologist will agree with you. Okay. So I had a nephrologist friend, very smart, and he said something. He said, "Oh yeah, sarcopenia," because I was talking to him about this. He says, "Yeah, you know what? If you send patients with sarcopenia to renal transplant, they don't do well, they die." And I was like, "Oh yeah, okay. So do you check for sarcopenia before you send them for transplant?" He said, what? I said, "Well, you just told me they die. Don't you want to know if this patient is at high risk for dying?" He said, "I never thought of that." And he said, "To be honest, I didn't even know how to check." And he said, I've always known this." I said, "So you send them like you don't know there's sarcopenia?" He said, "You know what? Why are you always asking funny questions?" He's like, so now you got me thinking. I said, "It's good." But the point is, if you actually correct the sarcopenia, the renal function improves. Okay. And this is the part where they know that they've seen this, right? I think that's what changed their recommendations for protein. They realize these patients, the sarcopenia is worse. Now, I just want to point one other thing out, which I think is really important. Cachexia is advanced accelerated muscle loss, right? Often seen that way. And you see that in cancer, it's people who get very gaunt. Now, 20% of people with cancer will die just from that alone, the loss of tissue, not from the cancer, not from the tree, 20%. So it's very serious. You see that in cardiac patients, end-stage heart failure, COPD patients, things like that, right? And the renal patients, right? So they can get cachectic, which is this advanced accelerated muscle loss with a strong inflammatory component. That is not actually, you see the muscle loss. Primarily, it's a fat problem. I think for that, you have to address the fat. Okay. And they have upregulation of UCP1, so a lot of browning inappropriately. So interestingly, you see the muscle going down, right? It's actually a fat problem. See, because it's linked. You have to look at fat muscle bone. So someone with cachexia, I don't treat the same way as someone with sarcopenia.
Mm.
Okay, because if you got to address the fat.
Yeah.
Okay, so that's again the distinction, and that's why we need to start getting a little bit more nuanced about metabolic health and not just I lost weight.
Yeah. Yep. No, I love that. Just think back, like, I don't know, 5 years, 10 years to the statement that you just said about exercise being good for the brain. It's not great for weight loss, but it's good for the brain. What an amazing thing we've learned about exercise. I would totally agree. I'm a personal trainer. Like, it's great. It's great for different things though than you might think. It's not that great for weight loss. It's great for other things.
It's huge for neuroplasticity. So I had an episode on shrunken brain syndrome, where with obesity, with increased visceral fat, even if you are a normal weight, the brain shrinks because of decreased blood flow. Now, it's very hard to regenerate the brain, but you can actually get the brain to rewire, which is called neuroplasticity, right? And the best way to get the brain to rewire is through movement and exercise.
Yep. I love that.
It's the best way. So, all these people are like, oh, well, what can I do about my brain? You gotta move. You gotta move.
Yep.
Right.
Yep.
You have to exercise, right? Because if you are prioritizing your brain, you gotta do that.
Yeah. I love that. I absolutely love that. And if somebody's thinking like, okay, I want to try a program, but I don't want to join the gym. I don't have space. I don't have like a lot of room for weights and things like that. You know what? Like yesterday, I went to Amazon. I bought a $30 set of resistance bands that go up to a very heavy resistance. You don't need hardly anything. You could watch YouTube videos. You could book a free 30 session with us. I can show you things. Like there's ways that you can do this at home with very minimal amount of equipment, and you can absolutely very much challenge your muscles to the point that you can elicit growth and have all of those benefits that you talked about. And again, I don't think many people consider that when you're lifting weights and you're using your muscles, your bones are flexing. They can become stronger. Now
and you're loading the bone mechanically as well. Now here's this thing, you're absolutely right. We the 2% of the population that goes to the gym, okay, but then the vast majority of people are quite sedentary and they're not doing much. But then we also have a sick population that isn't able to, right? They're confined to wheelchairs, and then they just get weaker and weaker and more sarcopenic. So that's kind of a vicious cycle there. But there are methods. So I did an episode on resistance training. I use a lot of isometrics, right? And I use eccentrics, right? I just use a yoga strap. So nobody's dropping because I've had a person drop 5 pound foot. Not, she did it on her own at home. I know 5 pounds on her own foot. And I'm like, you know what? I just don't want people doing that, right? So I just use a yoga strap. And then recently I've started using these weights that you fill them with water. They're amazing because you have to stabilize your core, right?
So hard. They're so hard.
Yeah. So they're great for travel too. I started playing with those. But like you said, you don't have to have a whole lot. Even body weight is really very useful.
Yep.
If you get people to do it right. I mean, when I start with a patient who is not very mobile, I get her or him to just stand up from the chair. And it's a modified squat, right? So chair stands. Do 10 of those every hour. Stand up 10 times every hour. People don't realize that you can, wherever you are, there's something you can do.
I love that. I love that. I couldn't agree more. And what a great way to end this episode. Another wonderful conversation with you. I'm going to put you on the spot. I would love to have you back for a third episode. You do a lot of work with immunity, and you have a certain way of explaining it that I certainly connect with really, really well. It's a very complex topic, but you make it very easy to understand. And so we would love to set up another time to have you back on so we can maybe do a deep dive into immunity, because again, not only do you understand it, but you have such a gift for taking something really complex and putting it in a way that's really more simple to understand, and something that I really appreciate. It's part of what I absolutely love about your podcast. So I know you're very busy. You don't have a ton of time, but if we can ever set up another appointment, I would love to talk to you about that.
I would love to do that. I love talking about the immune system. I'm very interested in immunometabolism. If I can give a plug, that talk that I gave at IHMC, the Magical Mystery Macrophage, MACROPHAGE tour. So if you're a Beatles fan, you'll know the reference. The Magical Mystery Macrophage tour, and I talk about macrophages and a very general overview And there are several layers of macrophages that I want to go into now. Why? Because eventually in the podcast, I would like to tackle atherosclerosis. Okay. And primary immune cell that's discussed in atherosclerosis would be those macrophages. So I started with a little intro. Eventually, I want to add layers of complexity to that. But yeah, immune cells, immunometabolism, really for me, those are the things I'm very, very interested in. So I'd be very happy and thrilled to come back and talk to you about those things.
Well, that would be fantastic. And for the listener, I will tag that video in the notes of this episode. So you can always just go down, follow the link, and you'll be able to get there. Because yeah, I think I signed up for that summit that you were in, and I ended up being really busy that week. And I've always been meaning to go back and like listen to some of the talks, and I just have not been able to. So I'll make sure to link that down below. Because yeah, it's just endlessly fascinating and so interesting to make those different connections. Very nuanced, like we talk about. We've talked twice about all of this stuff is very complex and nuanced. So again, we thank you so very much for taking the time to come by our show. Where do you want people to go to find you and connect with you and your work?
My website, VyvyaneLoh.md.com, VyVyaneLohMD.com. And my podcast is called VLMD Rounds. And that's the name of the YouTube channel as well. So they can look there. And I'm, happy to have people give me their comments and request topics. I take requests. So there's a topic that you're interested in, like if you want to hear about immune cells, I'm happy to go and dive in. And then the other thing is I also do live Q&A sessions on that YouTube channel. So people can check my website for the upcoming Q&A sessions, because that's when people often will give me their requests or ask me certain questions about things that, supplements that they're doing and different practices that they may be trying and so forth.
Yeah, that's fantastic. We'll link to all that in the show notes. I'm assuming your website is where they can also subscribe to your newsletter?
Yes. Yes.
Okay,
absolutely.
great. I subscribe to very, very, very few newsletters, and I'm going to rush downstairs and subscribe to that right now.
Yay!
So,
and like I said, I personally do everything myself. So I write the whole newsletter. I only got time to do it one time a month, folks. So you're not going to be inundated. You get it one time, because I'm
That's
like,
great.
Oh shoot, I got to do
great.
this now. Yeah.
I love people who do everything themselves. It's so savage. I absolutely love that. That's great.
Don't have a choice.
Yeah, exactly. And it's cool on YouTube. Like I can get podcast reviews, but YouTube, I can interact with people. So I really enjoy that too. So I certainly understand. Dr. Vyvyane Loh, thank you again so very much for spending time with us today on this fascinating topic. And we look forward to having you again.
It's been a pleasure.
Such an honor to have you. And this has been another episode of Boundless Body Radio.